Have Brian Blase, who's sort of right in the heat of things. So he speaking on Trump administration policies on transparency, choice, and competition. How does he know about that? Well, he helped write it. So he is former special assistant to the president in the White House and the National Economic Council, and is going to give us sort of an update on what's going on in Capitol Hill with some of the things that we're talking about now. So thanks very much, Brian. It's all yours. So we can.
Thanks, Dan.
Great, awesome, okay.
Thanks, Dan. Appreciate the opportunity to be with you. I'm going to talk about past, present, and future Trump administration policy to expand choice and competition in healthcare markets. I'm really going to start the story with the failure of Congress to pass legislation in 2017 to deal with problems related to the Affordable Care Act or Obamacare. You know, the president often does these impromptu press conferences on the South Lawn while Marine One is revving its engine, and White House staff are sort of always very eager to hear what the president's remarks are going to be. Sometimes a little nervous about what the president's remarks might be. But there was in late September, after the final sort of ACA modification bill was pulled from the Senate, the president gave one of these press conferences and said not to worry. He wasn't giving up. Health reform was important. He had an executive order that would be signed within a week or so. The I's were being dotted, the T's were being crossed. Now, some White House staff reacted to this news with a sense of trepidation, maybe others with a little bit of horror, since we had no executive order on what the president mentioned, association plans, buying across state lines. But we took it to mean the president wanted to lead here and his direction to his staff to come up with actions that could help Americans, particularly those in the middle class that had been harmed by previous government policy over the past decade, as well as small businesses and their workers that were dealing with rising healthcare costs. So we drafted an executive order within it's the one that's on your screen right now on enhancing healthcare choice and competition across the United States. And the president signed it on October the 12th of 2017. That order led to 4 actions, 3 regulatory changes that expanded choice and competition. I'm going to highlight those 3 and then sort of talk about the administration's broader vision and actions to increase choice, competition, and transparency in healthcare markets. The first action that executive order led to was an expansion of association health plans. Association health plans are ways that small businesses can join together, get some of the economies of scale and regulatory advantages that large employers receive when they offer coverage. The rule was actually off to a successful start with this new pathway that we created. Unfortunately, in March last year, a federal judge blocked it, has an invalid expansion of ERISA. The Department of Labor and the Department of Justice brought suit, brought an appeal to that decision. Appeal was heard in November, and we're still waiting for the outcome of that appeal. The second expansion, which was really just undoing actions of the Obama administration late in 2016, was expanding Americans' ability to purchase short-term limited duration insurance. These are plans that have existed for decades, and federal regulation on these plans was always just about setting the time that these people could maintain these plans for. And from HIPAA, from the rules in HIPAA in 1997 through rulemaking in 2016, people have been allowed to purchase these plans for up to 364 days. The Obama administration was concerned that people were preferring these plans to ACA plans in the exchanges, and shut the contract period to 90 days and prevented consumers from renewing them. We believe in consumer choice of health insurance, and we basically reversed the Obama administration restrictions on those plans. The Council of Economic Advisors issued a report in early 2019 that estimated the net benefit of the actions of the combination of three actions: eliminating the individual mandate tax penalty, which was largely borne by lower class Americans who couldn't afford ACA compliant coverage, expanding AHPs, and expanding short-term plans. And there is real economic benefit in consumer choice. Council of Economic Advisors estimated that those three actions provided Americans with $45 billion of net benefit each year. The third regulatory rule change, the one that took the longest to get through the three departments, and which I think is the potentially to be the most profound of the actions, is an expansion of something called health reimbursement arrangements. HRAs are ways that employers can use tax-preferred dollars to reimburse employee healthcare expenses. One of the problems with employer-sponsored coverage is that employers assume a lot of the power to make healthcare decisions for hundreds of millions of workers. 80% of companies that offer a health plan only offer their worker a single choice of plan. And what we wanted to do was allow employers another way to offer health insurance that has the same tax treatment, so that workers have more choice and control over the coverage. So what we did was finalize a rule that allows employers to provide contributions in health reimbursement arrangements, and workers to go and pick coverage that works the best for them in the individual market. All told, we expect this rule is going to take some time for employers to learn about, to get comfortable with, but by the middle of this decade, we expect about 800,000 employers will offer HRAs to their workers, and we'll have 11 million people enrolled in the individual market with these HRAs. In contrast to the ACA, the individual market is about 2 million people larger. There's about 2 million more enrollees in the individual market now than there were pre-ACA. We're spending about $50 billion a year in premium subsidies for individual market coverage. A simple cost-benefit analysis shows that's about $25,000 per year per newly insured enrollee. The HRA rule should add 4 times as many people to the individual market with no new federal spending, with leveraging employer contributions so employees can purchase coverage that works best for them in the individual market. Now, one of the opportunities, I think, for bipartisan reform going forward is to improve the individual market, to make the individual market a more attractive place where employers can offer coverage for employees and employees' family members. I think we are seeing with the pandemic, one of the problems with tying health insurance to the place of work is that when people lose jobs, they lose their health insurance. Health insurance should be portable, and workers and families should have much more choice over the types of plans to purchase. The fourth element of that executive order was much broader than addressing problems with the ACA and the individual market. It was really, and we've heard lots of the presenters earlier today talk about issues related to choice and competition and problems with government rules that restrict consumer choice and that protect inefficient incumbents from competitive forces. Really, we were aimed at taking on the 3 primary problems in America's healthcare system. The first is, and the previous speaker and many of the speakers have talked about, the misaligned incentives, the overabundance of third-party payment in our healthcare system. 90% of spending runs through third-party payers. Pervasive third-party payment creates a web of complexity and the feeling that we're all spending other people's money. And perhaps most importantly, a disconnect between providers and consumers where providers can be serving the interests of the payer instead of the consumer. There are parts of the healthcare sector where third-party payment is rare: LASIK eye surgery, plastic surgery. And there we've actually seen, declining prices over time and increased quality over time. And the key is that providers are directly competing for consumer dollars. There's also a lack of price transparency. So one of the things that the administration is focused on, and which I've done a lot of research and writing on recently, is the benefits of price transparency for both patients and employers, from giving them more tools to be better shoppers of healthcare. The second big problem are government policies that limit choice and competition. Dr. Feldstein, I think, well articulated these in his presentation. You know, I often quote Harvard Business School professor Regina Hertzlinger from her book, Who Killed Healthcare? And she has this great quote that choice supports competition, competition fuels innovation, and innovation is the only way to make things better and cheaper. So with less choice and competition, we have less innovation in healthcare. Government rules can suppress competition and often keep providers from practicing to the full extent of their abilities. And when government imposes these excessive entry barriers, they're often not responding to legitimate consumer protection concerns. They're propping up a profession that has become immune and grown used to not having to deal with competitive forces. Perhaps most problematic are the state certificate of need laws that require healthcare providers to obtain permission from a state authorized agency, or even existing providers to construct new healthcare facilities, expand existing ones, or often certain healthcare services. The evidence to date suggests that these laws are often costly barriers to entry that don't control costs or improve care. We have pretty sufficient, substantial evidence that greater competition incentivizes providers to become more efficient. The third key problem, which again has been raised, I know by the first speaker, is the growing market consolidation. According to recent analysis, nearly 4 out of 5 Americans in urban areas live in highly concentrated hospital markets. The more concentrated hospital markets, the higher prices that people have to pay. We know that after mergers, after hospital mergers, both vertical and horizontal mergers, prices can increase by as much as 20 to 50%. And we have the issue of those vertical mergers with hospitals increasingly buying out physician practices. The Choice and Competition Report is 120 pages. When people criticize the Trump administration for not having a healthcare plan, I always point them to the Choice and Competition Report. We spent a year working with the Department of Labor, Department of HHS, Department of Treasury, Federal Trade Commission, and the Council of Economic Advisors, the policy councils within the White House, the Office of Management and Budget, to create a really robust health reform plan built on expanding choice and competition and taking on government rules that restrict choice and competition and transparency in markets. Now, some of them are federal. A variety of the restrictions are state imposed, like scope of practice requirements, certificate of need laws, restrictions on doctors from licensed in other states from practicing within a certain state. But we really wanted to put out sort of a guide for free market healthcare reform. It could be used hopefully for a long period of time for both policymakers at the federal and state level. Here, there's 4 chapters in the Choice and Competition Report. These are the 4 sections: the healthcare workforce and labor markets, healthcare provider markets, healthcare insurance markets, and consumer-directed healthcare. Of those, I would say, you know, there's, I mentioned the 3 key problems with healthcare. So, you know, policy often functions on the margin. What can we do on the margin to improve the healthcare system? And I would say there's really 3 things we could do whenever possible on the margin. We push to expand consumer choice and control. And I mentioned that's a large part of what motivated the administrative actions coming out of the failure to modify the ACA. To enhance market competition, to take on narrow scope of practice requirements, to take on restrictions on telehealth that don't make sense, and hopefully the expansions that we've had on telehealth at both the federal and state level will persist after the pandemic is over. And the third is really to redirect government subsidies. So government, the federal, the state governments spend so much on healthcare, and really it's about subsidizing a third-party payment system. I think where we need to focus is redirecting subsidies away from third-party payments to first-party payments. So Senator Johnson, one of the things he talked about was catastrophic health insurance coverage with HSAs. I think one of the most profound things we could do is have universal HSAs. Right now, you can only have a health savings account if you have a specific high deductible health plan that meets other requirements. I think everybody should be able to have an HSA regardless of how their health plan is designed. A HSA that they grow wealth with when they're young and healthy, they build wealth. and they're able to use that as they get older and have more expensive medical needs. Finally, I'll spend one more minute. I often talk about the choice and competition executive order as healthcare executive order 1.0. My last week at the White House was in June 2019. The Monday of that week, the president signed what I call executive order, healthcare executive order 2.0. It's this executive order on improving price and quality transparency in American healthcare to put patients first. Cynthia Fisher spent her presentation talking about the benefits of price transparency. Again, I think that is one of the key aims right now of the administration. They've finalized a rule that requires hospitals to post their price information. They're going to finalize a rule requiring insurers to post their price information probably later this summer or early fall. I think price information is going to help consumers and employers better navigate the healthcare system, figure out how to do things like reference pricing designs. So I have 2 slides on reference pricing. Reference pricing is a great way to provide price information and an incentive for consumers to act on that price information. So the California Public Employee and Retirement System used reference pricing in 2010 for orthopedic procedures. And reference pricing is where the payer sets an amount that that they're going to pay, and that's the amount regardless of the provider or facility where the consumer goes. It's a great way, it turns out, to incentivize shopping among consumers. And you can see here when reference pricing was implemented in 2010, you have a significant change in consumer behavior from going to from high-priced providers to low-priced providers. And the neat thing is that the high-priced providers responded to the consumer change in behavior and lowered the prices. And you can see the red line is the CalPERS, the reference pricing, the switch in the high-priced providers. The blue line is the control group, so the employees that weren't part of the reference pricing model. And there was a significant change in the high-priced providers lowering their prices because of the increased competition. With that, I'm not going to do the last slide, but I have written a piece 2 weeks ago with Lan-Hee Chen of the Hoover Institution. It was in the Washington Times. A link is on there, and it is our proposed health reform agenda for the president for 2020.
Great. Thanks, Dr. Blase. This was great. We're at time, so there's a detailed question about the HRA. If you have time to answer it sort of through text. Just real quick.
I love talking about HRAs, so fire away.
Real quick, just a clarification. Earlier, were you referring to the ICHRA rules? That was a while back. So.
Yes. So
okay.
For those of you that don't know what ICHRA is, that's the individual coverage HRA. So that's the HRA that can be integrated with, that can be used to purchase an individual market plan.
Yeah. So I think, unfortunately, we're going to have to move on. But I just want to comment that, you know, Senator Johnson and you advocating for a universal HSA, that experiment was done in Singapore. That's why they spend 2.5% of GDP and we spend 18%. So there's evidence for this.
Good luck getting us down to 2.5%.
Yeah, I'd be happy if it didn't go to 20.
Yeah.